Good afternoon, and thank you very much. First of all, I would like to thank the chair, the co-chair, and the organizer for inviting us here. I think the program has been tremendous, and I congratulate the whole organization committee for putting up such an excellent program. Right. I'll go straight to my case. This is a 40 years old man who works as an executive, went for a routine annual checkup, found to have a fasting blood glucose of 168 milligram per deciliter, and A1C of 8%. There are no comorbids, hardly gets time to exercise, is a non-smoker, and BMI of 27. I think this is a bread and butter case for everybody who works in endocrinology or diabetes. My predecessor, Dr. Shaminda, he just said the king was insulin, but then when he showed his slide, he said the real problem is the resistance. So I don't think insulin is the king. The king only works when you take account of the resistance as well, which is where the sensitizers come in. Now, what are the treatment options available for our executive? What treatment apart from lifestyle changes and medical nutrition therapy are required? Before I go, I think this is a case discussion, and I would want you to think about it, what is important. For that, I would like you to go with me through a list, and I think that will give you a good understanding of how to use the sensitizers and in what case and what kind of sensitizers you want to use. Now, we need to know what is the basic pathophysiology of type 2 diabetes. We also need to know what parameters do we use for better outcomes in type 2 diabetes. We need to know what is the long-term safety data regarding treatments in type 2 diabetes. Is cost a consideration in the environment where we are living, the part of the world where we are living? Of course it is, and that has to be considered. And what are the recommendations of different endocrine and diabetes organizations? So straight going to pathophysiology, I think this is pretty straightforward, and I think it has been seen time and again. You can't have a presentation on diabetes without having this slide. And this is important because, you see, it's the insulin resistance which is way before anything else has happened. That's about 10 to 15 years before actually diabetes has occurred. And this is the core problem. And this problem remains. So I think insulin resistance needs insulin sensitizers to work. And I think when the diagnosis of diabetes comes in, by that time, the horse which was running is already tired, which is beta cells, and there's a deficiency of beta cells, and this is where you diagnose diabetes. So I think insulin resistance remains the core problem that need to be addressed. Insulin deficiency, yes, that need to be addressed as well in some cases, because that is maybe number 2 king, I would say. And then we now know that there is another problem, which is deficient incretin action, which has been alluded to earlier by one of the presentations. So with these three, insulin resistance being the core problem, relative insulin deficiency is the second problem, and impaired incretin action the third problem. These are what we know of problem with diabetes, or pathophysiology of diabetes. But for the purpose of this presentation, I will be only touching the first part, which is the insulin resistance and the drugs which overcome this insulin resistance, which are 2 drugs that we know of, which is metformin and TZDs. So the next question that I put to you was, what are the parameters that we use for the better outcomes in diabetes? I think apart from many parameters, one of the parameters we use is, and I will be more glucocentric here, is the HbA1c. And you know that if you reduce the A1c, the outcomes are better, both in microvascular and macrovascular complication. I think micro has been talked again and again. It's the macro which doesn't get attention and which is getting attention these days. Now, what are the outcomes of macrovascular outcomes? Now, people don't die of retinopathy, do they? People don't die of nephropathy quickly. People don't die if they get amputation. They live. What do people die of is a heart disease. And that's what we need to look at. And from one estimate, it's about 3 to 4 times higher risk of heart disease in patients with diabetes compared to non-diabetic. And I think that's why we need to look at drug from that perspective, that what are the drugs which are safer or sometimes even better in heart disease. So from that perspective, we need to look at the drugs and the safety. So let's look at metformin. Do we have anything available for metformin? Well, let's look at the mechanism of action. It has the action mainly is glucocentric, what we look at, but there are many actions, and we know that we give insulin sensitizers to people even without diabetes, like a polycystic ovarian syndrome, some form of cancers, in which metformin is being given. So these are only few actions that we know of. There are other actions which we don't know of. So it reduces the hyperglycemia by reducing the gluconeogenesis at the liver, glycogenolysis, and reducing fatty acid oxidation on the liver. It also works on skeletal muscle, insulin-mediated glucose uptake, increased glycogenesis, and reduced fatty acid oxidation, and hence it reduces the hyperglycemia, and then it has got effect on the gut as well. Now, metformin, we know by all means, knowing the pathophysiology, which is insulin resistance to begin with, it is the first-line drug. Now, the evidence, the second evidence which I wanted to talk about is whether there's effect on CV risk cited in international information for sulfonylurea and in US and European associations. Now, in US prescribing information, they say that there's no clinical established studies conclusive of evidence of macrovascular risk reduction, but European insert does say that there is evidence, and one of the evidence was from UKPDS, which I'm going to allude to. Some people who are overweight and who are given metformin, they have got a better outcome as far as the cardiovascular morbidity and mortality is concerned, and that is shown in this trial. If you look at this UKPDS 34 study, what it shows here is that metformin arm is better than intensive control and then the convention arm. And this legacy remains for 10 years. So if you give to overweight diabetic a metformin, which is our case here, is executive who's overweight and is a newly diagnosed. So if you give somebody a metformin, a sensitizer, they've got a better outcome in terms of glucose monitoring, and also they've got a better outcome in terms of cardiovascular mortality in the long term. So generally, metformin is recommended as a first-line therapy because it's one of the strongest insulin sensitizers, and there's some evidence to suggest that CV benefit in overweight patients, and there remains a positive evidence for long-term placebo-controlled cardiovascular outcome trials in terms of metformin. The other sensitizers that we have now is TZDs, or thiazolidine diones. Does anybody know who he is? Anybody knows? No. Well, he's a famous Steve Neeson cardiologist. Now anybody knows who Steve Neeson was? He's the man who's responsible for loss of $12 billion to the industry, pharma industry, because of the meta-analysis which was done on rosiglitazone. And these are the two drugs which were taken out of the market because of the meta-analysis which Steve Neeson gave back in 2007. But we know that TZDs are a good sensitizer. They work right at the cellular level. So if you look at the skeletal muscles, liver, adipose tissue, at adipose tissue, it increases the fatty acid uptake, lipogenesis, and increased glucose uptake at the adipose tissue, thus reducing the plasma-free fatty acids. And it also works on the liver by reducing the gluconeogenesis and also glucose uptake at the skeletal muscle. So all is good for TZD, but what happened? Where did we go wrong? Why we are not using as it should have been used? The result was this meta-analysis, which was done by Steve Neeson on rosiglitazone, and what it shows was there was increased myocardial infarction in meta-analysis done. This meta-analysis, by the way, was done on 42 studies altogether. So 42 studies meta-analysis showing that rosiglitazone actually causes more cardiovascular deaths than compared to a comparator. But then there was another meta-analysis almost at the same time of 19 studies done on pioglitazone, which showed exactly opposite. So we don't know what happened. What it shows was there was a reduce in MI of hazard ratio of 0.81, which is about 19%, and then reduce of death in patients who were using pioglitazone. So there was no critical direct comparison, but these meta-analyses did show that there's a difference between the two molecules, pioglitazone and rosiglitazone. So one of the major trials which was including in the meta-analysis was proactive trial, and what it showed was done on more than 5,000 patients. It was the primary endpoint was time for the occurrence of all-cause mortality, non-fatal MI, stroke, ACS, endovascular surgery, so very strict primary outcome, coronary artery, leg arteries, intervention, amputation above the ankle, very strict primary outcome. But the secondary outcome was time for the first occurrence of all-cause mortality, non-fatal MI, and stroke. So what does the proactive show? Proactive showed that there was superior to placebo mainly for secondary outcome, but not for the primary outcome. It also showed there was increased heart failure cases in the group which was using pioglitazone. So knowing that it has got a good effect on adipose tissue, it has got a good effect on liver, it has got a good effect on muscle, but despite that, the outcome was not as it was expected in a primary outcome first. And the other important point was there was more cases of heart failure. As good the drug it may be, but it causes increased heart failure. So we've got to be careful for that. There was another trial, and this trial was done just about the time when the meta-analysis in 2000 was being done. So you can imagine that the meta-analysis is done, which shows there's increased cardiac mortality of the person who's using rosiglitazone, and this trial is going on. Obviously, people who are being recruited in rosiglitazone arm didn't want it to be included. They wanted to get out of the trial, and that happened. So there was a lot of dropout rate in record trial, and it was an open label, so anybody who was on rosiglitazone wanted to be out of the trial because of the Steve Nielsen's meta-analysis. So because it was open-ended, a lot of dropout, the primary endpoint was time for first occurrence of cardiovascular hospitalization or cardiovascular death, and the secondary endpoint was time to first occurrence of all-cause mortality, non-fatal MI, and stroke. And remember, this was again more than 4,000 patients. So, you know, it was a very good trial, but the timing was wrong. And what it showed, this trial didn't show increase in cardiovascular death. As a result of that, FDA in 2013 voted to reduce the safety restrictions on rosiglitazone, but I think by then the damage was already done. Nobody wanted to use rosiglitazone, and I think some of the stick got up to pioglitazone as well, knowing that the pioglitazone is a different, although the class is the same, but it's a different molecule, and it works slightly differently, particularly on the lipid part of the metabolism. So there was no long-term prospective data on safety data, so the controversy still remain. So in terms of cardiovascular safety, TZDs cause or exacerbate heart failure, we know that. Some CV meta-analysis in 2007 suggested differencing effect on CV outcomes. I've shown you the pioglitazone meta-analysis, and I've shown you the rosiglitazone meta-analysis. Both are different, though the same class of molecule. Pioglitazone was associated with significant 16% reduction in 3-point MACE, whereas a secondary endpoint versus placebo in a proactive trial. A rosiglitazone open label record trial showed no increase in CV death, but as again I said, it was a time when everybody was taking a stick against rosiglitazone, so nobody took a notice of this very good sensitizer which was available. So as I said, FDA reduced, but the controversy remains. And I think we need to understand that although in the same class, even if the molecule works the same way, there's a different effect of different drugs. And I think that is what is a classic example in the case of TZDs. So is cost a consideration in almost a pandemic disease? This morning it was shown that diabetes is not epidemic, it is almost a pandemic, at least in this part of the world. So cost is a consideration. I'm sure it's a cost consideration in our part, in Sri Lanka, in Bangladesh, India, Pakistan, all these safest countries. So we've got to be realistic in our part of the world. What is the evidence that it is important? Now, WHO always print a list of essential drugs. The essentials are the life-saving, important drugs. Without that, and they are for the whole world, not for the richer countries. Now, in WHO essential medical list, if you see, there are 2 drugs which are anti-glycemic, and if you look, the metformin stays there. So sensitizer, because we know, is a drug which is a good sensitizer, it's a cheaper drug, so it remains available to us. What are the recommendations of different endocrine and diabetes organization in terms of sensitizers? Now, if you look at any ADA, ESD, NICE, IDF, and even SAFEs together, or SAFEs individual countries guidelines, all of these recommendations says that sensitizers needed to be used first, particularly metformin in our patients with type 2 diabetes. So we come back to our case, Mr. AB, 40 years of age, and incidentally found to be diabetic and is overweight. So what do we do? What are the options? Let's go for the option. I've given you a list. So what are the possible treatment options? We need to, whenever you are treating the patient with sensitizer, you need to consider diabetes pathophysiology, which we need to consider. We need to consider weight, and you must understand that whatever the drugs are coming these days, any drug which reduces the weight or is weight neutral is considered to be better drug. So we need to use a drug which is weight neutral, which is metformin. If the drug causes weight gain, which is in case is TZD, may not be a better choice. We need to consider whether the drug which we are using causes hypoglycemia. We need to consider the combination, whether we are using with SGLT2, insulin, sulfonylurea, any drug. We need to consider the sensitizers in all group of drugs. We need to consider metformin intolerance, because that is one thing where the TZDs can come in. And mind you one thing, you don't need to use the higher dose of pioglitazone in patient who is requiring insulin sensitizer, because even a smaller dose works similarly as compared to a higher dose, and maybe the side effect profile may be lesser. You need to consider cost when you are considering a treatment option, and you need to consider bone health, renal function, and a heart failure in patients who are being using sensitizers for these patients, because in TZD's case, there is an evidence that it causes bone demineralization. So what we are looking, the options we are looking for is basically a perfect therapy. Now, for perfect therapy, we need to have a good glycemic, anti-glycemic effect. We need to have a better micro and macrovascular outcomes. We need to have a perfect drug which doesn't cause hypoglycemia, which doesn't cause weight gain, or at least should cause a weight loss. And we need to have a drug which have got a lesser side effect. That's our perfect drug or perfect therapy. And we need to consider a drug which doesn't cost too high, and it has got a non-glycemic benefits. Now, unfortunately, I don't think there is a perfect drug available, but what is available is the choices. And we need to pick up the choices, what has been given before by my co-presenters. So we need to look at the benefits, glycemic controls, outcomes, and we need to look at the evidence, what is available, and we need to look at the harms which any drug would cause, including hypoglycemia, side effects, and weight gain. We need to consider the cost, again, availability, cost effectiveness, and patient acceptance of any of these drugs or sensitizers. With this, I thank you all for your patient listening. Thank you very much.